Welcome back to another lecture of Express Revision course of Complete Denture. This is Dr. Sangeeta and you are watching Dental Pathshala. So if you want to watch more interesting videos like this, you can check out our playlist. You can search in the YouTube Dental Pathshala and you will find more interesting videos in the playlist. And if you like the video, give it a thumbs up. Also, you can subscribe to the channel to get more free videos like this. You don't have to now take notes while you are studying with us, because in the notes you will find everything which is provided is in the link in the description below, or else you can visit our website www.x2.com, wherein you will find notes of all the videos. So this is a continuation video of the Express Revision course, wherein we are going to cover high yielding points for the competitive exam, either it is a NEET PG exam, NEET MDS exam, or any other competitive exam. So we are not covering everything here. So last video we have covered the definition, steps and the case history part, and last video we have also covered the case history and then PPS, recording the PPS, the mandibular anatomical structures, anatomical landmarks of the mandible, and the tongue, that and impression. So today's video will be starting with the RRR, residual ridge resorption. So today this part is the residual ridge resorption. So residual ridge resorption, or we can say triple R, residual ridge resorption, is basically, as the name suggests, residual ridge and resorption. So we are talking about resorption of the residual ridge, right? So resorption of the residual ridge. So reduction in the volume, reduction in the size of the residual alveolar process is the residual ridge resorption. So the classification of residual ridge resorption is very important. Classification. In that, the most important classification is the Atwood classification. So if you want to watch all these videos in detail, if you want to cover, you can watch in the playlist Complete Denture. We have got separate playlist for Complete Denture, wherein you will find the Complete Denture videos. So talking about the Atwood classification is when there is the tooth present in the ridge, right, and there is a bone resorption still taking place. So this is going to be the class 1, which is the pre-extraction. So we are talking about before the extraction, when there is a resorption, then that is the class 1 Atwood RRR. Then the second part is the post extraction. So this is the empty socket. So class 2 is the post extraction. After the extraction, then 3 is the when there is, after the extraction, the ridge is highly well rounded. So high well rounded ridge, which is the class 3. Usually when we are talking about ideal, we talk about in the class 1, but here in the class 3 is the highly well rounded ridge. Again, this highly well rounded ridge is very good for the retention of the denture, stability and support of the denture. Class 4 is our knife edge ridge, when due to the resorption of the from the buccal and from the lingual side, the resultant residual ridge is a knife edge. So what happens when we give denture in that patient? There is, because of the pressure, the point area, there is going to be pain when the patient wears the denture. So knife edge ridge, class 4. Then we have got class 5, which is low well rounded ridge. So here is the rounded, but it is low. So low well rounded ridge. Then class 6 is when there is going to be depression in the ridge. So when the ridge is depressed, so this is the depressed ridge. In case of severe residual ridge resorption, what happens? There is going to be small gonial angle, right? So what happens after the extraction? There is going to be resorption of the bone. So the most resorption, the maximum resorption, we must say, the amount of residual ridge resorption is maximum first year after the extraction. So first year after the extraction, the amount of ridge resorption, amount of residual ridge resorption is 2 to 3 millimeters for the maxilla and 4 to 5 millimeters for the mandible. That means if you look at, if you have done the CD cases, you must have seen that there is going to be resorption of the mandible more than the maxilla. So first year after the extraction also the mandible ridge resorption is more. Later on stages also the mandible ridge resorption is more. So you have to remember this, that whenever we are taking impression, we see that while we are taking secondary impression or border molding, we see that there is going to be good suction, there is going to be good peripheral seal for maxilla, but mandible we don't get. Usually we see the mandible bone resorption is more. So this is very easy for you to remember because that we have seen clinically. So first year after extraction, the amount of residual ridge resorption for the mandible is 4 to 5 millimeter. Later on, second year, third year after the extraction, the resorption is reduced. So it is 0.1 to 0.2 millimeters for the mandible. That means maxilla is going to be lesser, even lesser than this. So maxilla is going to be 4 times lesser than the mandible. Then residual ridge resorption, because in the mandible it is more. So the mandible is wide and wide mandible, let me write wide mandible, and the maxilla becomes narrow. How it becomes narrow? So what happens in case of residual ridge resorption? In the maxilla, the resorption is in the upward and the palatal direction. And in the mandible, the resorption, now we'll be talking about two things, anterior and the posterior. So in the mandible, anteriorly, the resorption is in downward and lingual direction. And because of that, now and the posterior it is downward and buccal. So downward and buccal. So what happens, because see mandibular, there is going to be, suppose this is the mandible, right? Suppose this is the mandible, alveolar process. Mandible anteriorly it is, resorption is from the lingual area, and mandible posteriorly is from the downward and the buccal area. So what happens? The resultant after the residual ridge resorption, so the mandible will be like this, right? So there is going to be the prognathic profile of the mandible. Actually it's not like this. Because of the resorption, the mandible, it becomes like this. So because of that, there is going to be the prognathic profile. The mandible becomes wide, the maxilla becomes smaller. So it is a kind of a class 3 relationship. So like how it is seen in the class 3. So because of that, there is going to be prognathic profile, right? So the residual ridge resorption is going to result in the prognathic profile of the patient, because the resorption is in such a way that the maxilla becomes small, the mandible become larger, because the mandible resorption is from the lingual side and maxilla resorption is from the palatal, upward and palatal direction, right? So residual ridge resorption ratio, RRR ratio, in the anterior maxilla, if we take a ratio divided by, ratio is the division, right, and the anterior mandible, it is 1:4. That means the resorption in the maxilla is less. If suppose there is going to be, for example, if the resorption in the maxilla is x, so resorption in the mandible is going to be 4 times the x. So resorption in the maxilla is 4 times less than the mandible. So resorption in maxilla is less. And the reason behind this is that the maxilla is a cancellous bone. So because of that, it absorbs and dissipates the forces. Then the trabeculae pattern in the maxilla are parallel to the forces. So they are parallel to the deformation forces. Then because of that, therefore there is going to be maximum resistance to deformation. That means the maxilla is going to resist the deformation. It will not let the deformation happen, right? And the ridge in the maxilla is broad, flat and cancellous. That is the reason the resorption in the maxilla is less and the resorption in the mandible is more. So in the mandible, there is going to be more resorption. So if we look at what are the factors influencing the residual ridge resorption, so if the forces are more, the resorption will be more. So that means the forces are directly proportional to the residual ridge resorption. If there are going to be bone resorption factors more, that means if the patient is having any bone disease, if the patient is having osteoporosis, that means the bone resorption will be faster. That means there is going to be resorption of the mandible. That means the residual ridge resorption will be more. So the bone resorbing factors also are directly proportional to the residual ridge resorption. So the amount of bone resorption factors, more the bone resorption factor, more is the residual ridge resorption. Then inversely proportional factors are the damping factors, the time, the more the time, the damping effect, more the damping effect, less is the resorption, more the time, less the resorption, because we have seen that first year after extraction is the most resorption. As we go towards the time, that means as we go 2 years, 3 years down the extraction, 2 years later extraction, actually the resorption is reduced, as you can see 0.1 to 0.2 millimeter. Otherwise first year after extraction it was 4 to 5 millimeters, right? So the time is also inversely proportional. And bone formation factors. So if there are going to be more bone formation factors, there is going to be the less chances of residual ridge resorption, right? So what happens in case of extreme bone resorption? Extreme bone resorption, or we can say extreme residual ridge resorption, will result in the mental foramen opening. Mental foramen opening, where they are opening directly at the crest of the ridge. So opening at the crest of the ridge, at the crest of the ridge. And what happens when, because see, mental foramen otherwise is a relief area, we give relief to the mental foramen in the area of mental foramen, right? So if we are putting pressure directly on the mental foramen, that means we are putting pressure on the mental nerve. So what will happen? Pressure over here will cause pain to the patient. So pressure in this region will cause pain over the sharp bone. So the patient will complain of pain in that case. So last video we have talked about the impressions. This video we are going to cover the special impressions. Special impressions. In that will be covering impressions in the hyperplastic area, that means the flabby tissues, and impression in the residual ridge resorption. So the first one is the hyperplastic or flabby tissues are present. Here, this is a picture showing the flabby tissues. The flabby tissues. This is the particular area, right? Hyperplastic or flabby tissues. Now, let's have a look at the flabby tissues first. So, the questions which are asked from the flabby tissues, first of all, the soft flabby tissue is undesirable, we do not want, and actually it affects the stability of the denture. So the denture is not going to be stable if the flabby tissues are present. And second thing is that if there are flabby tissues, what will happen? The flabby tissues either are to be surgically removed or we can relieve it. Now, what are the cases where we remove the flabby tissues? What are the cases we manage it in the denture? So, if there are excessive flabby tissues, then definitely we have to go for the surgical removal, right? Surgical removal. And if they are not excessive, then we can manage it via the special impression techniques which we are going to cover just now. Special impression technique. And most important thing is that if flabby tissues are present, we are going to ask the patient to do the finger massage in that area. So that is going to increase the circulation. So the finger massage is also important. Next, talking about the special impressions in the flabby tissues. Now we have got two kind of special impression, two techniques we'll be talking about. There are many techniques, but the two are important for the competitive exam point of view. One is the Hobkirk single tray impression. Also, if you want to watch residual ridge resorption, you will find the video in the playlist. You have to go and search for the complete denture. In that you will find, but these videos are in Hindi. So, the single tray technique. This is the Hobkirk single tray technique. The another one is the window technique. Another one is the window technique. If you can see here in the diagram, I have made a window over here. See, can you see a window? So this is the area wherein we have created a window. That means the denture base, or the custom tray, we have trimmed it in the area of flabby tissues in case of a window technique. So talking first about the single tray impression. Single tray impression technique is very easy. So which was given by Hobkirk, and first of all we do the border molding. Then the impression which we use is the heavy body elastomers, heavy body silicone impression, right? And then the movable tissues we cut in the impression. So cut the movable tissues, and then taking the wash impression of that particular area, wash impression of the movable tissues, we take it from the light body. Like this is the same way how we take a dual impression in case of FPD, right? First of all the heavy body impression, and then scraping off that particular tissues and taking a light body impression. Or also you can use the plaster, impression plaster. So you have to remember this. When we have in the last video we have talked about that the mucostatic impression wherein we are not putting forces. So basically in the hyperplastic or the flabby tissues we need to remember that we take a mucostatic impression of the flabby tissues because the tissues are already moving. What happens? They see this area is already moving, okay. So when this area is already moving, if you put pressure, it is going to move to and fro. So what do we want? We want to make it static, so we are not putting pressure over here in this area. So we are taking impression from such a material which is not putting pressure, that is the mucostatic impression technique, and we have covered in the previous video that mucostatic impression material is our impression plaster. So talking about the window technique. So window technique, what we do, first of all, window technique was given by Zafarullah Khan. Okay, then what do? We make a window or we make a hole. So a window or a hole is created in the custom tray in the area of the flabby tissues, area of the flabby or movable tissue. So wherever the flabby or movable tissue are there, flabby tissues. Okay, so wherever the flabby tissues or movable tissue are there, the custom tray we are going to first trim it. The first impression we take is the mucocompressive impression. Rest of the area, remember this, mucocompressive impression is the rest of the tissues. And if we talk about the flabby tissues, we are going to take impression from the impression plaster, which is our mucostatic impression, right? So impression plaster of the flabby tissues. So then the impression plaster is painted over the flabby area. So we are going to paint, that means put impression plaster over here in the flabby tissues, and then we place the tray, we take a mucostatic impression. This is a mucostatic impression in the window. So mucostatic impression in the window. So that is why window technique, because from a burr we are drilling or cutting out this particular area, right? So we have created a window. Talking about the special impression, this one is the hyperplastic or the flabby tissues. So the next one special impression is our RRR, residual ridge resorption, or we can say the atrophic ridge. When there is going to be, see, this is very important because clinically most of the times we get the atrophic ridge, highly resorbed ridge in case of mandible. So it is very important for us to record a very good impression in case of a resorbed mandible. So if you are doing a clinical practice, again it is going to help you out. So we are going to cover 2 impression techniques. There are many, again you will find in the playlist there are many techniques, but this video we are going to cover only 2 most important. So which is the McCord and Tyson, and you can remember it, McCord and Tyson admixed technique. Okay, so McCord and Tyson admixed, Mike Tyson, you can remember from Mike Tyson, M for McCord, T for Tyson. The other one is the cocktail. So the Mike Tyson is having a cocktail, you can remember for the residual ridge resorption. So the another one is the cocktail. Very important, McCord and Tyson, we are going to take 2 materials. First of all, we use it for the atrophic or in case of a flat mandible. So it is used for a flat or a atrophic mandible. And what we do is we take a combination of impression compound plus green stick. So the impression compound and the green stick we take in a ratio of, so this is the impression compound, then we are going to take the green stick, and they are taken in the combination of 3:7 parts. That means out of 10, 3 part in the mixture is going to be of impression compound and 7 parts are going to be of green stick. Okay, so this is the admixed McCord Tyson admixed technique in which we are taking impression compound and green stick. Green stick, remember that we are taking more green stick compared to the only 3 parts of the impression compound and 7 parts of the green stick we are taking. So this is the McCord and Tyson admixed impression, which we use for atrophic and flat mandible. Next one is the cocktail impression. What we do in case of cocktail impression, we are going to use the closed mouth technique. So we are going to use closed mouth technique. That means we are going to take impression when the patient has closed the mouth. So what we do in this case, suppose this is the maxillary denture base, this is the mandibular denture base, and we are going to put acrylic pillars, or we can say acrylic stops. So these are the acrylic pillars. Or acrylic stops between the maxilla and the mandible. So these are the acrylic pillars or the acrylic stops. So what do? We take a impression, closed mouth impression with which material? With the admixed material. So the material with the admixed material, with the admixed technique, okay. So the material which we have used in the McCord and Tyson, which is the combination of impression compound plus green stick in the ratio of 3:10. So in the ratio of 3:7, So 3:7 parts. So this is about the atrophic mandible, residual ridge resorption, McCord and Tyson, and cocktail. And the cocktail impression, and this is for residual ridge resorption. And for hyperplastic or flabby tissues, we take from a mucostatic impression material, which is our impression plaster, or we can also use the light body elastomers for the flabby tissues. Flabby tissues main aim is not to put pressure, because already these tissues are mobile, so we are not supposed to put pressure. So we take via the help of a window technique, right? So guys, now talking about, we are finished with the impression. The cast, important point for the cast is width of the cast. Width of the cast. So width is 10 to 12 millimeter on average, which we take. Talking about the border molding. So border molding is molding the peripheries or molding the border in order to get a peripheral seal or in order to get a good retention. So there are two techniques. One is the sectional or incremental technique. Another one is the single step. That means we are in sectional technique, we are going to do the borders in the sections. In the single step, or we can say the simultaneous. So in that case, we are going to do the border molding of whole of the denture in one shot. So in the sectional, which we have been doing in our clinical practice, is the sectional. That means we are going to see, suppose if this is the stock tray, custom tray, then we are going to do in sections. We are going to do the labial, then frenum area, then we take the buccal area, then we go posteriorly, then we do the PPS. So like that, we are going to do in sections. And in case of single, we are going to directly put material all over the borders and we are going to record in one shot. Right. So sectional or incremental, the material which we take is the green stick, which we do in the clinical practice. Single or simultaneously, most common material is the polyether. So polyether is the most common material which we take. Also we can use for a single impression material, silicone impression materials we can also use. Then we can also use impression waxes. But if they are asking about most common, then we have to again go for the polyether, which is the most common, right? So after border molding, after the border molding is done, we are going to remove the wax spacer, but over the PPS is not removed, right? We all have done this, but not the PPS. Then when we are doing the border molding of the mandible, so it is very important, border molding of the mandible, then we are going to check the custom tray. And first of all, in the mandible, custom tray for both the maxilla and the mandible, the custom tray is 2 millimeters short of the vestibule. Two things, both are 2 millimeter, 2 millimeter short of the vestibule and 2 millimeter again is the thickness of the custom tray. Thickness, right? So both are going to be 2 millimeters. So in the mandible, the custom, we have to check that the custom tray is not moving, will not displace, and we have to check if the custom tray is stable, right? So I have check in the mandible, we have to check that it is stable. Then border molding, when we are doing for the lingual border of the mandible, lingual area if I am writing, that means the mandible only. If palatal I am writing, that will be obvious, then it is maxilla. So lingual border of the mandible impression, there are 4 muscles which are involved: the palatoglossus, superior pharyngeal constrictor, mylohyoid muscle. If you are watching this video and if you find it slow, you can watch it in, you can increase the speed of playing and you can watch it. So, genioglossus. So, the distobuccal extension, very important. The distobuccal extension of the border is due to the masseter, and the distolingual extension of the impression is due to the superior constrictor. So lingually, if you see, then we have got pharynx, right? In the pharynx we have got superior constrictor of pharynx. So in the buccal area we have got masseter. In the lingual area, we have got superior constrictor of pharynx. Then comes the beading and boxing. So we do the beading and boxing and then we pour the secondary impression, right? So beading and boxing of the secondary impression is very important. Then the secondary impression, we do the beading and boxing. And secondary impression, while we are taking secondary impression, most of the time we are taking zinc oxide eugenol impression paste, right? After that we are doing the beading and boxing of the ZOE. So beading and boxing of the ZOE can be done in 2 ways. One is using the caulking compound and another one is using the metal strip. And when we combine both of them, then the method we call it is the caulking compound and paddle boxing method, which is done for ZOE, zinc oxide eugenol impression paste, right? So the another method for doing beading and boxing, see, the first one is the caulking compound and the paddle boxing method. The another method is plaster and pumice method. Plaster and pumice method. This method we do it for when we are taking impression from the rubber base material. That means the elastomers. When we are taking impression from the elastomers, see, when we are taking impression from the rubber base material, then we cannot put wax because the wax is not going to stick. So wax cannot be used for rubber base impressions. So in that case, we are going to invest the impression, which we call the beading. So beading is investing the impression into the impression medium, and the impression medium or the investing medium, that is the box, that is the beading, right? So beading is the investing and boxing is the investing medium, so which is our pumice and plaster combination. So that is why it is known as plaster and pumice. So the medium we are going to invest the impression in is a combination of the pumice and the plaster. Now that we have the secondary cast, we are going to make record bases and we are going to make the occlusal rims. So construction of occlusal rims, which is again a lab step. So we are going to construct the occlusal rims on the record basis. We have got maxillary and the mandibular. So the question that can be asked is the dimension of the occlusal rim. So the anterior height of the occlusal rim is going to be 22 millimeters. The posterior height is going to be, okay, let's just change the color. So the posterior height is going to be, okay, I cannot change. The posterior height is going to be 18 millimeters. I hope that you guys can see. Okay, this might work for us. So 18 millimeters, yes. So the posterior height is 18 millimeters. The anterior height is 22 millimeter. Now talking about the width, which is anteriorly it is 4 to 6 millimeter. Posteriorly it is a bit wider, which is 8 to 12 millimeter, right? So the height anteriorly it is 22 millimeter. We have already done in the PCP labs in the preclinical. We have made lot of occlusal rims. So 18 millimeters posteriorly. See, this anteriorly it is from the canine eminence. From where? From the canine eminence. Posteriorly it is from the depth of the sulcus. Right. Width if we talk about. So width is anteriorly it is 4 to 6 millimeters. Posteriorly it is 8 to 12 millimeters. Right. Width posteriorly is more. Height anteriorly is more. Now, if we are talking about the occlusal rims when measured from the crest of the ridge, measured from the crest of the ridge, then height or the length, we can say height or the length. Anteriorly it is going to be 10 to 12 millimeters and posteriorly it is going to be 5 to 7 millimeters. Right. So this is the measurement. Height anteriorly is 22 millimeters when measured from the canine eminence. So to be corrected, it is going to be, so okay, it is to be corrected, it is going to be from the canine eminence. So from the canine eminence it is going to be 22 millimeters and posteriorly when measured from the depth of the sulcus 18 millimeters. But if measured from the crest of the ridge, anteriorly 10 to 12 millimeter, posteriorly 5 to 7 millimeter, and the width anteriorly 4 to 6 and 8 to 12 millimeters. Okay friends, now let's take a deep breath and a glass of water because we will be talking about jaw relations. So we'll be talking about jaw relation and mandibular movement because we are going to do some movement side by side. In order to understand the movements better, we need to do the movements, right? So we'll be talking about the jaw relation and the mandibular movements. You know, there was a time I used to get scared of jaw relation, mandibular movements. So it used to be so hard, as if I have to fight in WWE. I used to fight with books literally like this. But now that I've understood it well, so it's very actually easy because it is just the movement, like how I'm talking, I'm doing mandibular movement, like how we are chewing, we are doing the mandibular movements. It is just so easy to understand, and most of the students have been asking me to prepare a separate video on the mandibular movements. We'll eventually make that video. So before that, let's do some mandibular movements. So the jaw relation, we have got three types: the orientation jaw relation, vertical jaw relation, and the horizontal jaw relation, right? Before that, we'll be talking something about little bit about the mandibular movements. So mandibular movement, see, this is the glenoid fossa, right? In the glenoid fossa, in the maxilla, we have got the condyle of the mandible. So what happens, this is the condyle, suppose. So what happens when the condyle is rotating to and fro like this? That means the condyle is not sliding or gliding. So when the condyle is rotating to and fro on its own this position itself. So it is not, condyle is not replacing its position, it's not changing its position. So this is our hinge movement. So this is the hinge movement where there is pure rotation which is happening. So this particular is the hinge movement. Hinge movement, you have seen doors in our houses. So if you open a door, the door joint is going to be in its own position, right? Suppose this is the door. So this is the handle. So the door is going to be fixed, attached from here. So it will just move here and there, to and fro, open and close, like that. So there is no other movement which is happening. So that is in a fixed plane, it is doing the movement. So that is the rotatory movement. So the pure rotation we are talking about is the hinge movement. And when this movement happens, when we are going to open the mouth 20 to 25 millimeter. So 20 to 25 millimeter, there is going to be the pure rotatory movement of the condyle. That means when we open the mouth 10 to 13 degree, up to 13 degree. So if I say less than 13 degree of rotation of the condyle is our pure rotatory movement or the hinge action or the hinge movement. So pure rotation movement is due to the lateral pterygoid. As we know that all of the muscles of mastication are going to close the mouth except lateral pterygoid, which will open the mouth, right? So lateral pterygoid, that we'll cover in the anatomy videos. So the lateral pterygoid is doing the pure rotation movement or the hinge movement. So this pure rotation movement or the pure hinge movement is, what do we call it? The terminal hinge axis. Now I'll be telling you two things. One is the terminal hinge axis. These all are similar terms. Okay, the another one is the transverse hinge axis. So hinge axis, we know that this is the pure rotatory movement. Up till now we are clear, right? We are not clear with all the concepts in the head, we are just clear with the concept here. So everything is still retained in our head. Hinge movement, it is very easy. See, it is in our head. If we think it's difficult for us. If we think it's easy for us. So everything is in our head. So we have to think it. Whenever you face your fear, whenever you face challenges, you have to think that it's so easy. Let's just do it and then we'll see if it is hard or difficult. So we are not making any opinion right now. We'll just try to understand what it is, and I am pretty sure that we'll be able to hack it. So hinge movement is the pure rotation of the movement. That means the condyle is moving to and fro. It is not going, there is no forward movement of the mandible till now. So this is the pure rotatory movement which occurs in the 20 to 25 millimeter of the mouth opening, and the condyle rotation is less than 13 degrees of the rotation of the condyle, right? So 10 to 13 degrees of the rotation of the condyle. Now we'll be talking about two terms. One is the terminal hinge axis. So terminal hinge axis term was given by McCollum and it was verified by Kohno. So what is there in the terminal hinge axis? As the name suggests, so it is going to be the hinge axis which is present at the terminal part. So when this is rotation axis of the mandible, but when the mandible or when the condyle, I must say, is at the uppermost, rearmost and the medial position in the glenoid fossa. Right. So as the name suggests, it is the terminal part of the hinge axis. Hinge axis is where there is a pure rotatory movement. That means condyle is just rotating. It is not gliding or sliding. Terminal hinge axis is the terminal part of that hinge axis. That means the condyle is at the terminal position. That means the condyle is at the uppermost, rearmost and rearmost and in the medial position. Now talking about the transverse horizontal axis. This is the transverse horizontal axis. So transverse horizontal axis is again the rotational axis of the mandible, but here the condyle is at the anterior superior position. So transverse position we are talking about. So anterior superior position in the glenoid fossa. Right. So this is the difference between two. In the terminal, the condyle is at the terminal position, but in case of transverse, it is in the transverse position, that is the anterior posterior position in the glenoid fossa. And the difference between these two is only 0.2 millimeter. So both the axes are 0.2 millimeter apart. Right. So this is about the transverse horizontal axis and the terminal hinge axis. Now that we know the terminal hinge axis is the rotation axis of the mandible, where the mandible is doing the rotational movement, right? So hinge axis is basically the rotational movement of the TMJ. So the rotational movement of the pure rotational movement of the mandible. Terminal hinge axis is when the mandible is doing the rotational movement and also is present at the terminal position, which is the uppermost, rearmost, medial position in the glenoid fossa. So the terminal hinge axis, if we have to calculate this or this terminal hinge axis, there are actually four ways. Okay, one is the true trial and error method. Okay, second one is the arbitrary method of locating the terminal hinge axis. One is the true. In the true we have got trial and error method. In the arbitrary we will cover, there are many methods we will be covering. The third one is the non-believers for the hinge axis. So some people say that we do not believe in the hinge axis. There is nothing known as hinge axis. So non-believers. And the fourth one is our split hinge axis. Split hinge axis. So some people, they believe that there are two axes of rotation, one in each condyle and both are parallel to each other. So that is the split hinge axis school of thought. So we have got a true, arbitrary, non-believers and split. So true hinge axis, we have got trial and error method which was given by McCollum, Again, Maculum gave the term hinge axis. I told you the terminal hinge axis term was given by Maculum and it was verified by Kohno. So Maculum gave the term hinge axis, that is why true hinge axis method was also given by Maculum, and the trial and error method. Talking about the arbitrary hinge axis, we have got many methods of locating. So we'll be covering only, first of all, let's just write the names. So we have got baryon point, we have got Geissy point, we have got Bergstrom point, and we have got Prothrow, Dinar point, TSN point. Like that we have got various points. Now first talking about the baryon point. So baryon point is, first of all we need to draw a line which is from the, see this is the, let me just show you once, this is the tragus, right? This is the tragus of the ear and this is the outer canthus. So we are going to draw a line from the tragus, posterior margin of the tragus up till the outer canthus of the eye. Okay. So this is one line, and let's just zoom it. So from the posterior margin of the tragus to the outer canthus of the eyes, we are going to go 13 millimeters anterior to this point. So if we mark 13 millimeters, somewhere it will be somewhere here, 13 millimeters anterior. So this is our baryon point. Right. Next, talking about the second point, so baryon point. Talking about the next one is our Geissy point. Right. So Geissy point is the most commonly used. Let me write. This is the most commonly used point. So Geissy point is, we have to mark from the anterior margin of the external acoustic meatus. So we have to go from the external acoustic meatus, from the external acoustic meatus up till the, okay, we have shifted it. One second guys. Yeah. So next point is the Geissy point. So anterior margin of the external auditory meatus to the outer canthus. So again we have to draw one more line over here. So another line is second point. We will be marking now the second point, which is 13 millimeters. Some books it is written 10, some book it is written 13. So this particular point is going to be the Geissy point. Right. So like that we have got Bergstrom point also. So Bergstrom point is, let's just draw one more girl over here, but we will not draw a hot girl. Okay, let's just draw ear. That where job can be done. This is the eye, right? So this is the eye. Now talking about the Bergstrom point. So we have to draw a line which is starting from the center of the spherical insert of the face bow. So face bow we have got rods which goes inside the ear. So one line which is from the center of this rod up till the eye. So one is from the center of the rod, insert of the face bow of external auditory meatus, right? Okay, this one. And the another one is the FH plane. So FH plane, if you remember, is the PO, right? In the ortho we have studied. So porion to orbital. So suppose if this is our FH plane. So if this is our FH plane, then the point is 10 millimeters anterior to this on the FH plane, 7 millimeters below the FH plane. So the Bergstrom point. So the Bergstrom point is 10 millimeters anterior to the center of the insert of the face bow, which is inserted into the external acoustic meatus or external auditory meatus, and it is 7 millimeter below the FH plane. Below the FH plane. So this point will come somewhere here. So this is the Beidstorm point, right? So like that we have got points for the arbitrary measurements, arbitrary method of locating the terminal hinge axis, and Geissy method is the most commonly used method, right? This is just to make you understand. So talking about the rotation movements. So the first one in the picture we have is the horizontal axis. So there is a horizontal axis which is passing both the condyles. This is the horizontal axis in the horizontal direction, and if we do rotation, suppose this is a pipe, and if you are rotating this pipe inward, then suppose if you are rotating the mandible, now you have to imagine right now that you have inserted, take your fingers and place it in your jaws near the TMJ and do this movement rotation, like how anti-clockwise rotation, okay, to be very honest, do this anti-clockwise rotations. Once you do this anti-clockwise rotation, rotate your mandible also. What will happen? You are going to open the mouth. So horizontal axis, when we are rotating, there is going to be opening of the mouth. Then we are going to do the vertical axis. So now there is going to be a vertical axis passing through the condyle. If you have seen in this diagram, the condyle we have passed a vertical road, and if you are going to rotate it in the clockwise direction, what will happen? The mandible will shift in that lateral direction. So there is going to be the lateral movement which is occurring at along the vertical axis. Then there is going to be a sagittal axis, and the sagittal axis there is going to be again laterotrusive movements towards the lateral. So this movement will occur along the sagittal axis. So talking about rotation around the transverse or hinge axis So what will happen if we are doing the rotation around the transverse or the hinge axis? That means we are talking about a line of rotation from the left side of the mandible to the right side of the mandible, which is our transverse axis, right? So there is going to be rotation from the left side to the right side. So what will happen? During this, there is going to be a protrusive movement. So this is the transverse axis. And the rotation is going to be the protrusive movement. That means the mandible is going to move forward. Protrusive movement. So what will happen during the initial movement of mouth opening? The transverse axis pass through the mandibular foramen. Let me write this point is also important. So during the initial mouth opening, the transverse axis is going to pass through the mandibular foramen. Right. So there is going to be. Now talking about the lateral movements. When we are doing the lateral movement, that means we are taking the mandible to one side. Suppose if you are doing a movement in this direction. So this is the left side of the patient. This is the right side of the patient. Okay. Left side and right side. Now what will happen when the patient is moving the jaw to the left side? What will happen? The jaw will move in the left side. Of course, if we are taking the jaw to the left side, then the jaw will shift to the left side, right? So this side on which the movement is happening is our working side. So let's just write here, this side is the working side and the other side is our non-working side, right? So if we are doing the left side of the movement, if the patient is doing left side of the movement and the mandible is shifting to the left, that means the side on the left is the working side, side on the right is the non-working side. So the left side there is going to be the outward, you can see outward movement. But when the movement is, if we see the movement on the right side, then there is going to be the forward and the downward movement. So there is going to be the downward like this and forward and also inward, right? And movement on the working side is outward, right? So the working side, which is also known as the rotating condyle, non-working side, which is also known as the balancing side, which is because it is going to balance the jaw. So the balancing side, which is also known as the idling side, right? So this is the lateral. When we are talking about the left side of the movement, then the jaw is shifting to the left side, then the left side is going to be the working side or the rotating condyle, the right side or the other side is going to be the non-working side or the balancing side. The rotation on the working side is going to be outward, rotation on the non-working side is going to be the forward and inward movement. Very easy up till now, right? Now when we are talking about the lateral jaw movement, suppose if there is a movement on the left side, so the jaw is going to shift on the left side, right? So the movement while the patient is doing the lateral movement, so there is going to be lateral shifting of the mandible from the movement of the condyle along the lateral inclines of the teeth. So this is the working side. This particular side is the non-working side, right? If we are talking about movement through this side, so towards the movement is going to be the working, very easy, and the opposite side is the other side is the non-working side. So recording in the non-working side, that means we have talked about that there is going to be the downward and the inward forward movement. On the non-working side, working side there is going to be the outward movement. So recordings in the non-working side, there is going to be some shift, some 1 to 4 millimeter of shift, which we call it the Bennett shift. Bennett shift. Then there is going to be the bodily movement. As you can see here, there is going to be a bodily movement of the jaw, bodily movement because of the lateral translation on the working side. So if we talk about non-working side, we have got the Bennett shift, and if we talk about the working side, then we have got the Bennett movement. Then we have the Bennett movement. So Bennett movement is the movement, the bodily shift, which is due to the lateral translation of the jaw. Because of the lateral movement of the jaw, on the working side is our Bennett movement, and the Bennett movement is 1 to 1.5 millimeter each side. Right. So, the Bennett movement 1 to 1.5 millimeter each side. The Bennett shift 1 to 4 millimeter on the non-working side. So, talking a little bit more about the Bennett shift. So, the Bennett shift is recorded on the non-working side. It is the shift 1 to 4 millimeter of shift. So, it can be of three types. There can be immediate shift, there can be precurrent shift, precurrent side shift, and there can be progressive shift, progressive side shift. So, the immediate shift is, as the name suggests, there is going to immediately shifting. Immediate shift. That means there is going to be the immediately shift. See, immediately lateral translation. So, from here, there is going to be the immediately lateral translation. During the first, okay, lateral translation first, okay. So, lateral translation immediately, first 2 to 3 millimeters. That means 2 to 3 millimeters there is going to be the lateral translation, lateral translatory movement, and after that there is going to be the forward movement. After that there is going to be a forward movement. So, up to 2 to 3 millimeter there is a immediate lateral translation, and after that there is going to be a forward movement, right. So, this is the immediate shift. The second one we have is the precurrent side shift. So, precurrent side shift is, again lateral movement is there and all. So, precurrent side shift is, there is going to be lateral movement rapidly and then the lateral movement which is slow, which is less rapid. So, first of all there is going to be a rapid lateral movement, then there is going to be a less rapid movement, then there is going to be a less rapid movement. Rapid movement. So, the lateral movement up to 2 to 3 millimeters again. So, all up we will be talking about up to 2 to 3 millimeter. So, there is going to be rapid lateral movement, then there is going to be the forward movement, less rapid. Coming to the third one is our progressive side shift. So, we are talking about the non-condyle, the Bennett shift, right. So, the Bennett shift which is on the non-working side. So, shift on the non-working side we are talking about immediate, precurrent. Immediate is wherein there is a lateral transition up to 2 to 3 millimeter first, and then there is a forward movement. The precurrent side shift is rapid lateral movement and up to 2 to 3 millimeter, and then there is less rapid lateral movement, less rapid lateral side. So, this is lateral side movement, lateral side movement. In the immediate shift there was a forward movement, but in the precurrent side shift there is a lateral side movement. Then the third one we have is the progressive side shift. Which is actually the Bennett shift, the Bennett side shift. right? So there is going to be only one movement, which is our linear lateral translation. So there is going to be only one movement, that is the linear lateral translation. Up to 4 millimeters, right? So we have covered the bayonet shift, immediate shift, the precurrent side shift and the progressive shift. Now talking about the bayonet angle. So the bayonet angle is, suppose this is the mandible, right? This is the condyle. Now the bayonet angle is when the mandible is moved. So suppose this is the mandible which is moved, right? So during the lateral jaw movement. So basically the bayonet angle is angle measured from the sagittal plane. One second. Angle measured from the sagittal plane of this and the sagittal plane, okay, it's not visible, and the sagittal plane of this. So this is going to be our bayonet angle. So this particular fellow is going to be our bayonet angle. When these 2 points meet, so this particular angle is going to be our bayonet angle, right? So this is angle is measured on the non-working side. First of all, non-working side, the angle between the sagittal plane and the path of advancing condyle. When the condyle is advancing into the lateral motion, into the lateral movement, so the path of advancing of the condyle in the lateral movement and the condyle, the angle between the sagittal plane when the condyle was at rest, right? So this is viewed in the horizontal plane. And the angle is about 7.5 to 12.8 degrees. But the option will be given 15. So if the option is given 15 degrees, it is the angle. How the bayonet angle is calculated in a Hanau articulator? So the bayonet angle in the Hanau articulator, which is given as L, is equal to h by 8, the horizontal condylar, h by 8 plus 12. So this is very important. L is equal to h by 8 plus 12. Ideally, the h is, we take it the 30-degree angle. So this is how we calculate in the case of a Hanau articulator. So this is in case of a Hanau articulator, right? So this is how we calculate the bayonet angle. So the bayonet angle is L is equal to h by 8 plus 12. So guys, hold on, we are halfway there, and you know that YouTube mein videos are very interesting. Every video is interesting. YouTube is very addictive. But we are watching the videos that are going to help us during our exam. So keep on watching and let's do little more, that is the movement in the horizontal plane. So movement in the horizontal plane, how we are going to check all these movements in which all planes? one thing is we memorize it as it is, other thing is we imagine. We are left with only two options. So you have to think that you are standing behind the patient and you are looking, patient is sitting on the dental chair and you are looking it from the above. So now take a glass slab, insert it in your teeth, between your teeth in the mouth, that is your horizontal plane. So between the teeth we are talking about, like how we take the Gothic arch tracing. Gothic arch tracing is the tracing in the horizontal plane, the plane which is parallel to the floor of the mouth, right? So in that, suppose this particular point is our centric relation. Now the patient is going to take the mandible forward. So when the patient is going to take the mandible forward, this particular point is the protrusive. Protrusive movement is we take up to 6 millimeter, right? So this is the protrusive movement. Then we ask the patient, these all are the naze excursion guide. Okay, some guide comes, then in that we ask the patient first to keep the mandible at rest, that is our centric relation. Then we ask the patient to take the mandible forward, which is the protrusion. Then we ask the patient to take the mandible to the right. Then we again ask the patient to take the mandible again to the protrusive, and then we ask the patient to take it to the lateral. So all these movements basically are our movements in the horizontal plane. And once we are going to combine all these points, then so this point is our right lateral, this point is the left lateral, and this is the protrusive point. So what is the shape which has come? It is a diamond shape. Very important. Diamond shape. So this is the diamond tracing. In the horizontal plane, we have got the diamond tracing, diamond shape, right? Diamond is this shape. So this is a tracing which come. So also another way you can remember is the horse. Horizontal is the horse, and the people who ride horse, they wear diamond. So horse diamond. The other way you can remember this, right? So the diamond tracing is seen in the movement along the horizontal plane. Now talking about movement in the vertical plane. Movement in the frontal plane, or we can say movement in the coronal plane. We are not talking about corona here. I know that everybody's head only corona is running. And then the vertical plane, right? So we are talking about when we are seeing from the frontal view. So imagine that you are seeing from the frontal view. That means you are going to place your hand and keep it in front of your face. So this is the frontal plane. Once we talk about the frontal plane, that means when the patient has closed the mouth, right? This is the point. And when the patient is taking it to the right, the patient left, the patient is taking it to the right, then the patient is taking it to the left. So this is the when the patient is taking to right, when the patient is taking to left. This is the centric relation, or you can say centric occlusion, because we know that in the CD the centric relation is same as the centric occlusion. And when the patient in the frontal plane we are talking about, okay, so when the patient is doing protrusive movement, again it is going to be in the same plane, because this is a 2D structure. So this kind of tracing is the shield tracing, right? So if the question has been asked coronal, not corona, coronal, if the question is asked vertical, or if the question is asked the frontal plane, then it is the shield tracing, right? How? Imagine that your hand is protecting your face, so it is acting like a shield. So the frontal plane, in the front of your face you are making a shield, so this is the shield tracing, okay. And the next one we have is in the sagittal plane. So in the sagittal plane, the movement of the mandible is in the shape of beak tracing. So you can also remember it like how the Sagittarius girls are beautiful. So sagittal, Sagittarius girls are beak beautiful. Or if you have any other way to remember, you can remember it that way. So in the sagittal plane, the beak tracing is there. Now talking about the envelope of motion, which is again very important. Envelope of motion we are talking about, that means all the movements in the three-dimensional plane we are talking here. So envelope of motion was given by Posselt, and it is the border movement in the three-dimensional space. So first of all, now we'll be talking not two-dimensional but a three-dimensional view. Suppose the patient is at the centric relation. Okay, now little bit ahead, centric relation and this actually the centric relation and centric occlusion, there is going to be 0.5 millimeter of variation. So centric relation to first of all, this is the centric relation. Then there is going to be tight movement, tight closure, which is the maximum intercuspation, cusp to cusp movement, right? Then the patient will take the mandible little bit forward. So the lower teeth are going to slide over the upper teeth. So there is going to be edge to edge movement here, edge to edge movement. Then the patient will take more mandible forward, then there is going to be a protrusive movement. Then we ask the patient to open the mouth wide. So the patient is going to do the maximum mouth opening. Then we ask the patient to slowly and slightly close the mouth. Okay. So we ask the patient to slowly and slightly close the mouth. So there is going to be the hinge axis, terminal hinge axis. So terminal hinge axis. And this particular area is the mouth opening to the terminal hinge axis, or we can say hinge axis to the mouth opening. Then from the terminal hinge axis, again the patient is guiding to the centric relation. So this is our envelope of motion, which is given by the Posselt. Right. So this is the border movement in the three-dimensional plane. Now one more thing is the chewing cycle, which is recorded in the sagittal plane. So chewing cycle is recorded in a pantograph, which is again a three-dimensional pantograph. To make it easier for you to understand, let's draw two teeth first. Suppose these are the maxillary teeth and here is our mandibular teeth, right? So what happens? First of all, imagine that they are in a contact. So here is going to be the contact. Then we open the mouth. We chew, slightly chew. We take slightly to the one side. Then we take slightly to the other side. And then passing on the inclines or the slope, we again close the mouth. So this is going to be a teardrop shape tracing. As you can see, this is a teardrop, right? Like a teardrop. So this is going to be a teardrop shape tracing, which is seen for the chewing cycle. So teardrop shape tracing. For the chewing cycle, it's recorded in the sagittal plane. Recorded in the sagittal plane. So the chewing cycle. Now talking about the orientation jaw relation. Orientation jaw relation, we are done with the mandibular movements. I hope that you guys are clear now with the mandibular movements, at least for the MCQ questions. You can now easily solve all the multiple choice questions which is required for your competitive exam. So orientation jaw relation, as the name suggests, it is going to orient the jaw. That means it is going to give the angulation. But angulation of what? It is going to give the angulation of the maxilla to the base of the skull. Right? So orientation jaw relation is actually giving the maxillary plane angle. So this maxillary plane angle, it is tilted in some patient. So that is how, if it is tilted in maxilla, then accordingly the mandible will also be tilted, or the mandibular relationship will also be altered, right? So it also affects the level of occlusal plane to the denture. So it is very important that we record the orientation jaw relation. So if we define the orientation jaw relation, it is the jaw relationship when the mandible is in, its most posterior position. It can rotate in the sagittal plane. Around the imaginary transverse axis. Passing through or near the condyle. So it is the jaw relationship when the mandible is in most posterior position, and it can rotate in the sagittal plane around the imaginary transverse axis, passing through or near the condyle. So how it is recorded? Basically, it is recorded with the help of a phase bow. So it is recorded with the help of a phase bow, right? So we'll be talking about phase bows. So phase bow is a caliper like device which is used to record the hinge axis relationship, that is the opening and closing axis, right? So this is a phase bow. Then we have got different parts of phase bow. So this particular area is the locking nut. Then we have got the U-shaped frame. As you can see, this is U in shape, right? This is U in shape. So this is the U-shaped frame. Then we have got the bite fork. This is the bite fork. If we talk about, we have got orbitail pointer. That means this is a phase bow for hanau, right? This is the orbitail. That means this is a phase bow for hanau. Then we have got the condylar rods. So in case of bite fork, and when we are talking about the bite fork, see, for kinematic phase bow, we attach the bite fork in the mandible, but in the arbitrary phase bow, we attach the bite fork in the maxilla. So we'll be talking about phase bows. So they are of two kinds. One is the kinematic, another one is the slidematic or the dinar type. So one is the kinematic phase bow, another one is the slidematic or the dinar type of phase bow, right? So kinematic phase bow is the phase bow that is going to locate the hinge axis properly. So again, talking about the bite fork. Bite fork for the kinematic phase bow is attached to the mandibular, and in the arbitrary, like our hanau is the arbitrary phase bow, right? So like in the hanau, so arbitrary phase bow, it is attached to the maxilla. So if you have seen your seniors or PG doing, or if you also have done the phase bow. So phase bow is kinematic type, which is used in the FPDs, which is used for the FPDs and which is used for the full mouth rehab. We use the kinematic phase bow. So basically there is going to be a long and complex procedure, and this is the reason that we do not use this kinematic phase bow in case of complete denture patient, because it requires a complex procedure. Then coming to slidomatic or dinar type. So in that we take intercondylar distance reading. So in the slidomatic or the dinar type, then there is going to be anterior reference point and there is going to be the posterior reference point. So the anterior reference point is for the CD. The anterior reference point is 43 millimeters, superior to the lower border of the upper lip. That means if suppose this is the upper lip, we are talking about lower border of the upper lip, that means this is 43 millimeters. In case of FPD, we take it 43 millimeters. This is the, these are the centrals, right? These are the laterals. Then we have got the canines. I know that the smile is pretty bad. So in the FPD, we are going to take 43 millimeters superior to the incisal edges. Right? The anterior reference point. Then the posterior reference point, we take it the external auditory meatus. So the posterior reference point is the external auditory meatus. So talking about more anterior reference point, like other anterior reference point. Other anterior reference point. We know that for hanau it is orbital. So orbital is the anterior reference point for the hanau. Then 0 to 7 millimeters FH plane. Nasion is the point for quick mount and whip mix. Whip mix and quick mount. Camper's line is the ala tragus line. So ala of the nose to the tragus is the Camper's line, right? Then there is going to be the 43 millimeters superior to the lower border of the upper lip. We have just now covered. Border of the upper lip is for slidomatic or dinar type, right? Or dinar type. So this finishes the orientation jaw relation. Next, talking about the vertical jaw relation. Vertical jaw relation is when we are measuring the jaws in the vertical. That means we are putting 1 point above the mouth, 1 point below the mouth. So we have got VDO and VDR. So which is the vertical dimension at the occlusion, vertical dimension at the wrist. So vertical dimension at occlusion is measuring the, suppose this is the nose, this is the lip of the patient, and then here is the chin. So what we are going to do, we are going to take 1 point above the mouth, 1 point below the mouth, and then we measure this distance. So if this distance is at occlusion, that means the occlusal rims are occluding. The patient is wearing occlusal rims. So this is the occlusion, that is the vertical dimension of occlusion. If it is rest, then that means it is vertical dimension at rest. So vertical dimension of occlusion is the point measured between the two arbitrary or between the two selected points, one above the mouth, one below the mouth. So basically it is the vertical height of the face in the centric relation, or centric relation in the contact basically, or we can say is in the centric occlusion, when the patient is occluding the teeth, CO, centric occlusion. And the vertical dimension, vertical height of the face at the physiological rest position is the vertical dimension at rest, which is the VDR. So VDO, which is the vertical dimension of occlusion, what happens when it is excess? That means there is going to be increase in the VDO. That means when the patient is closing the mouth, then the closure of the mouth is not, it is supposed to be less, but it is more. Then what happens? There is going to be stretching of the muscles. Stretching of the muscles, or we can say straining of the closure muscles. Right? All the muscles which closes the mouth will be stretched, and there is going to be increase in the freeway space. What is freeway space? See, freeway space is the space between the vertical dimension of rest minus vertical dimension of occlusion, which is usually 2 to 4 millimeters measured in the premolar area. Right? This is the freeway space. So there is going to be increase in the freeway space, and freeway space is VDR minus VDO, which is 2 to 4 millimeters in the premolar area. So then we talk about the vertical dimension at rest, which is the vertical height of the face. A 1 point arbitrary, 2 points both are arbitrary, are selected points, one above the mouth, one below the mouth. When the mouth is at physiological rest position, is the vertical dimension of rest. Always remember this, that vertical dimension of rest is greater than the vertical dimension of occlusion. Suppose now, vertical dimension of occlusion, which is very important. So now imagine that you are sitting silently. Your teeth are not contacting. There is a space which is present between the upper teeth and between the lower teeth, which is the freeway space. Now close the mouth. Clench it, close the mouth. If you see that the height between the tip of the nose and tip of the chin is reduced because the space is diminished now. The freeway space is not there, right? So VDR, which is the vertical dimension of rest, is equal to freeway space plus vertical dimension of occlusion. So it is a combination of these two spaces. Vertical dimension of rest is important, is very important in complete denture because it provides a guide in CD, as it provides a guide to the vertical dimension to occlusion, provides a guide to VDO. So it is very important in complete denture as it provides a guide to the vertical dimension of occlusion. Rest gives an idea about the occlusion. So what happens if there is increase in the VDO? If there is increase in the VDO, there is going to be decrease in the freeway space. Freeway space. Now, very important, the patient should be sitting upright exactly, and the head should not support the head support. That means the position should be upright position of the patient, as the position of the mandible is actually influenced by the forces of gravity and also influenced by the posture of head. So the Reed's baseline, which is the inferior orbit to the center of the external auditory meatus. So the Reed baseline should be parallel to the floor while we are recording the vertical jaw relation. So what will happen when there is increase in the vertical or decrease in the vertical? So what happens when there is increase in the vertical dimension and when there is decrease in the vertical dimension? So what happens when there is increase in the vertical dimension? That means the vertical height we have increased. That means we have increased the vertical dimension of occlusion. So there is going to be increase in the increase in the lower facial height of the patient. Increased lower facial height of the patient. Lower facial height. There is going to be, because see, when we have increased the vertical dimension of occlusion, that means the patient was supposed to be occluding at some low level, but we have increased the bite. So what will happen? The muscles of cheek will come in between the teeth. So there is going to be the cheek biting. Right? So there is going to be difficulty in swallowing, difficulty in speech, difficulty in swallowing, and there is going to be stretching of the closure muscles of the face. So there is going to be the stretching of the muscles. Stretching of the muscles. You will see that the patient face will look like the elongated face. Elongated face. And there is going to be pain and clicking in the TMJ. Because the muscles are stretching all the time. They are not resting. So there is going to be pain and clicking of the temporomandibular joint. Right. So the very important is the cheek biting, which is seen in the increasing in the vertical dimension. Now talking about when there is decrease in the vertical dimension. So what happens when there is decrease in the vertical dimension? That means we have decreased the vertical dimension of occlusion we have decreased. So what will happen? There is going to be increased trauma to the tissues. Increased trauma to the tissues. Then there is going to be decrease in the lower facial height. So decrease in the lower facial height, increase in the lower facial height, facial height is seen with increase in the vertical dimension, but decrease in the lower facial height will be due to reduced vertical dimension of occlusion. Since there is decrease in the lower facial height, so the height of the lower face will look small compared to whole of the face. So because of that, there is going to be folding present at the lips. So the lips will be like this. So there will be folding which will be present in the lips, and the facial height will be reduced, like, right? So there is going to be reduction in the facial height, lower facial height, and the corners of the lips will be folded. Because of that, the patient can have angular cheilitis, or the patient can have angular stomatitis also. And angular stomatitis can be due to two reasons. Angular stomatitis can be due to either decreasing in the vertical height, decreasing in the vertical dimension of occlusion, and also due to the vitamin B2 deficiency, right? This we will cover in the oral path. So also there is going to be difficulty in swallowing, pain, clicking, discomfort, but compared to increase in the vertical facial, it is going to be less. So there will be loss of lip fullness. Lips will look very thin in the patient with, if we decrease the vertical height, there is going to be loss of the muscle tone of the lips, and the thin vermilion borders. So lips will become thin. Lips looks like thin. So thin vermilion border of the lip. Right, of the lips. Corner of the mouth will turn down. That means the patient will look like as the patient is sad. And also there is going to be obstruction of the opening of the eustachian tube, and the reason is that there is going to be the elevation of the tongue, or there is going to be elevation of the mandible, and because of that the soft palate will be elevated, and due to this there is going to be obstruction of the opening of the eustachian tube. Right. So this is about if we decrease the vertical facial height, if we decrease the vertical dimension of occlusion. So this is the difference. What happens if we increase the vertical height? What happens if we decrease the vertical height? Now talking about the horizontal jaw relation, we have covered the orientation, in that we have covered the face bow, the vertical. Now talking about the horizontal jaw relation, wherein we are going to cover the centric relation. So the horizontal jaw relation. The horizontal jaw relation is it of two types, the centric CR and the eccentric. Eccentric are, other than the centric, all the movements are eccentric. Eccentric, it can be protrusive, it can be lateral movements. So protrusive or the lateral movements. So centric relation, what is centric relation? It is the, we have been studying this from long back, from third year, final year. This is the most asked definition for the exam point of view, and centric relation, we all know it is a must definition, that it is a maxillomandibular relationship in which the condyle articulate with the thinnest avascular portion of their respective disc. That means the condyle are going to articulate in the thinnest portion of the disc with the complex in the anterior superior position against the slope of the articular eminence. That means there is going to be the anterior posterior positioning against the slope of the articular eminence, and this position is independent of tooth contact. So CR, there is no tooth contact. So CR is bone to bone contact. There is no tooth contact in case of CR. And this position is clinically discernible when the mandible is directed superiorly and anteriorly, and it is restricted purely rotary movement around the transverse horizontal axis or around the hinge axis. So there is going to be rotation of the hinge axis, rotatory movement of the condyle. We have studied that rotatory movement of the condyle happens when the mouth opening is 20 to 25 millimeters, or when the condyle rotates below 13 degrees. So 10 to 13 degrees rotation, we see that there is going to be pure rotary movement, which is the centric relation. So what is the need of recording the centric relation? Centric relation, see what happens in the CD patient. Okay, in the CD patient there are no teeth. Since there is no teeth, there is no PDL. Since there is no PDL, there is no proprioceptive impulses, right? Since there is no proprioceptors, so the patient has got no impulses, patient has got no control over the mandibular movement. Since there is no occlusal contact, so patient has no idea where to close the mouth. So what we need to re-establish. Re-establish a record wherein the condyle are going to be smoothly sitting in the glenoid fossa. That means the condyle are nicely resting, spreading the legs, and there is going to be no pain in the muscles. So this is a record which we want to re-establish. So basically, centric relation acts as a proprioceptive center to guide the mandible. So if the patient is having a good CR, there is no TMJ pain. If the CR is incorrect, the patient will complain of the temporomandibular joint pain. So centric relation is also known as the retruded contact position, RCP. So the retruded contact position, right? Now, it is the most unstrained, most retruded, anatomical, functional position of the condyle in the glenoid fossa, which is independent of, which is independent of tooth contact. Independent of tooth contact, which is very important. We are not talking about the maximum intercuspation. Maximum intercuspation is when both the teeth are occluding well. In centric relation, the teeth are not occluding well. So this is the difference between centric relation and centric occlusion. Centric occlusion is when there is tooth to tooth contact. So centric relation is when we are talking about position of the condyle in the glenoid fossa. So when we are talking about position of the condyle in the glenoid fossa, this is the centric relation. When we are talking about the teeth are occluding well, right? So when the teeth, maxillary teeth are contacting well, right? So that case we are talking about centric occlusion or maximum intercuspation, right? So this is bone to bone contact, centric occlusion is teeth to teeth contact. So this is the difference. And the current concept of centric relation says that the condyles are present in the superior anterior position. So the current concept is superior anterior position resting on the posterior slope of the articular eminence with the disc which are properly interposed. So basically it is a repeatable reference position. That means whenever we are going to take, the patient will guide in the exact location. So it is a repeatable reference position to mount the cast on the articulator. So the easiest way, I'll tell you how to guide in the clinical practice. See, sometimes theory is different than the clinical work, especially in a country like India. We are not talking about America and all, but the practical which we do is something different. The theory which we read is sometimes different. So the easy way to guide the mandible to the centric relation is when we are asking the patient to swallow, then the patient will automatically come to the centric relation. When we ask the patient to touch the tongue to the palate, then also immediately the patient will come to CR. And if we ask the patient to relax the jaw muscles, then also the patient will come to centric relation. Or if we ask the patient to protrude or retrude the mandible. So you know what happens, the easiest way is when the patient is sitting outside, and if we want to take a centric relation record, that day you are asking the patient to do the jaw movement continuously. Okay, so what happens, the patient muscles will get fatigued. Once the patient muscles will get fatigued or tired, the patient will automatically take the mandible in the most comfortable position, which is going to be the centric relation. So this is what we do in the clinical practice. So what are the methods to guide the mandible to the CR, mandible to the centric relation? So the methods are the swallowing or the free closure, wherein we are asking the patient to swallow the saliva, swallowing, or the free closure. Right. Another method is chin point guidance. From the chin, we are guiding the patient to the centric relation. Chin point guidance. Then one more is chin point guidance again, but this time we are guiding the chin with the help of a deep anterior deprogrammer. So if the patient has got some other centric relation which is not correct, so we are correcting it with the help of deprogrammer, with the anterior deprogrammer, like the Lucia jig. And the last one is the bilateral manipulation. So bilateral manipulation technique. So all these technique, who all give this technique is important for our exam. So the swallowing or the free closure was given by Sahanahan. The chin point guidance was given by McCollum. So many things have given. Then we have got chin point guidance with anterior deprogrammer as our Lucia jig. Bilateral manipulation technique was given by Dawson. So wherein we guide, we stand behind the patient and we are going to engage our fingers in the mandible, and we are going to put our thumb area, not exactly the thumb area, the palm area near the condyles, and we are going to guide the mandible. So that is the bilateral from both the sides. That is why the bilateral manipulation. And let me tell you some easy ways also. So there are some easy ways to guide. Easy ways. What are the easy ways? I have already told you. Having the patient swallow, to ask the patient to touch the tongue to the palate, relaxing the jaw muscles, or protruding or retruding. Protruding or retruding. Now talking about the methods of recording the jaw centric relation. Now that we know that this is the proper centric relation, we need to record that centric relation and then transfer it to the articulator, right? So that we can arrange teeth in that centric relation. So what are the methods of recording? So we are going to take the centric relation record and transfer it to the articulator. So we have got methods of recording the centric relation. We have got a static method. We have got a functional method. Then we have got the graphic method. Other method like radiographic method. Then we have got physiologic method. Right. So the static method is wax and plaster record, right? How we take it. Wax and plaster. Then functional, we have I'll tell you functional 2 method. One is the swallowing methods. One is the swallowing methods and other one is the chewing technique. So the other one is the chewing technique of Needlehouse and Patterson. So in that of Needlehouse and Patterson, in that we are going to take the metal beads and the styli, right? Needlehouse and Patterson. So graphic method, there are again 2 methods. One is the intraoral tracers, and another one is the extraoral tracers. So tracing, we are doing graphic is recording with the help of tracing. So intraoral and extraoral tracers, right? So again, the example of intraoral tracers are Seidel tracer, Bollard tracer, and we have got the measurement tracer. How can we remember this? Measurement tracer. How can we remember this? So you can remember it like this: into the C, a ball of meat. So you can remember is into is our intra, C is our Seidel, ball is the ball, meat is the measurement. So this is the into the C, a ball of meat. This is the intraoral tracer. Now talking about the extraoral tracers. Extraoral tracers we have is the Stansbury tracer. Then we have got the height tracer. Then we have got the Phillips tracer. The Phillips, which we use to straighten our hair or trim the beard, right? Then we have got the Sears tracer. Also you can always remember it because we use it extraorally, no? We do not put the tracer inside the mouth or oral cavity because we don't have any hair inside. So talking about the extraoral tracer, you can remember is extra stand, the heights of Phillips. So extra is extra, stands is Stansbury, height is height, Phillips is Phillips. So extraoral is extra stands, the height of the Phillips. So we have got static method, functional we have got swallowing method or chewing method of Needlehouse Patterson. Graphic we have got extraoral, intraoral. Intraoral we have got into the C, a ball of meat, which is the Seidel tracer, Bollard tracer, measurement. Extraoral Stansbury, height, Phillips and Sears. The radiographic we have got cephalometries, ceph. So what happens while we are recording CR? If we put extra pressure, if we put excess pressure in recording the CR, it is going to cause the displacement of the soft tissues, definitely. Displacement of the soft tissues, and therefore extra pressure during the CR is actually avoided. Displacement of the soft tissues, and this effect is known as the Reelf effect. Reelf effect, which is also known as the resiliency-like effect. Resiliency-like effect. Right? This is the Reelf effect. So if we put extra pressure while recording the centric relation record. So guys, from the articulator we are going to cover